I'm going to get started if that's okay. Welcome everybody. Thank you for joining us at the very last session of the day. I know that's huge. Yay for you, you're not shopping. Some of our other colleagues maybe are shopping. We're also at the really other exciting workshop. Come on in, Emma. Hello. So I'm going to draw us together, and I'm very pleased to introduce this next workshop, so engaging community partners. And the previous workshop was about it kind of engaging consumers and people living with HIV, and this is more about it working with community agencies and the sort of big C community. So today we're going to, I'll just go over our objectives. Can you hear? There you go. I'm too quiet?
Yes.
Okay, I'll speak louder. So we're talking about engaging community partners. I'm going to start off with a presentation by Pacific AIDS Network and their colleagues. Do we have the workshop objectives? Sorry. I'm just going to review the objectives with you. So we're going to review the findings of the STOP community engagement working groups, community level and community-led evaluation. We're going to also talk about best practices in engaging community partners, strategies that the team used to determine the needs and priorities for engagement, and the role of community partners in prevention, testing, and support. We're going to hopefully speak frankly about some of the challenges and the mistakes that we made, and also speak about the lessons learned. So I'm going to very pleased to start off with a presentation, and I'm going to introduce my two colleagues. So Janice Duddy and I have worked together for many years, and she was the Provincial Health Service Authority's HIV/AIDS manager for the past 8 years, and she's currently transitioning into a new role at BCCDC's hepatitis program. So we're sad to see her go, but also sure we'll still see lots of her. And also going to introduce Evan Jones, who's been working in the community-based HIV and hepatitis C sector since 1996. Evan's well known as her role as Executive Director at Pacific AIDS Network for the past 5 years, and previously she was ED at YouthCo AIDS Society, Friends for Life as well. So over to you two.
So good afternoon, everyone. Yes, thanks, as Megan said, thank you for persevering. It's great to have still a small and robust group here at the end of the day. So just on behalf of the STOP Community Engagement Working Group, I just wanted to say how pleased we are to present the findings of a community-led, community-based evaluation of STOP that was undertaken under the auspices of the STOP Community Engagement Working Group over the past year. So basically, this STOP Community Engagement Working Group is a subcommittee of the STOP Leadership Committee. And I can't exactly recall what year we formed this, the CUG, we call it the CUG. But I guess probably about a year ago, we came up with this concept of, we recognized that STOP, the pilot project pieces at least, were starting to wind down, and we thought it was really, really important to insert the community-based voice into the evaluation of how the pilot projects had evolved. And we didn't want to look at the patient experience at all, and really the focus of this work was on approaching primarily AIDS service organizations, but also related community-based organizations, and engaging them on an evaluation process of the STOP pilot projects. So I just want to acknowledge the community members or organizations that were represented on the Community Engagement Working Group, and that really helped to contribute to this project. So the CUG was comprised of, first and foremost, people living with HIV and AIDS. And in terms of organizationally, we had PAN, the Red Road Network, Central Interior Native Health Society, Positive Living North, Vancouver Native Health Society, and the Dr. Peter AIDS Foundation. And then as well, on the committee, we had representatives Janice Duddy, Kath Webster, and Irene Day from the STOP Leadership Committee.
So the STOP Leadership Committee endorsed the recommendation to move the community-based evaluation forward, and we want to say a big thank you to Vancouver Coastal because they found the funding to help support this work. move forward. One of the reasons why we wanted to do this work is that we were starting to hear anecdotally that there may have been like a ripple effect happening outside of the pilot regions. So the pilot regions for STOP, as we all know, are in Vancouver and in Prince George, but we were hearing that there were people on the island and in the interior that maybe were aligning work with STOP, and we wanted to see if there had been a ripple effect to STOP across the province, and to work with our partners in aid service organizations and community-based organizations to ask about that, and to ask them about their experiences with STOP and their learnings from STOP, and with a future thinking hat on, how they could align their work with STOP if there were to be a provincial rollout. At that point, we didn't know if there was going to be a provincial rollout or not, but we thought it was an interesting question to ask. And we brought on Kim Vanderwoord and her team at Reciprocal Consulting to do this work. They worked their buns off over the summer, which is a very hard time to get a lot of input and feedback and participation from community. But that said, they had gotten amazing feedback. There was a lot of interest from community-based organizations and ASOs to contribute and to have a say and to provide feedback on the STOP project. And so we say a big thank you to Kim and her team. And they're going to come up in just a second and present their findings. I just wanted to let you know that we have two resources. So we have the full report from the community-led, community-level evaluation, and as well as it's 81 pages long, and it's got a lot of fascinating information, and it tries to encapsulate like the incredible amount of data that was collected. And then there's also a 5-page, very pretty looking summary document, and they're both down here at the front table, so if you're interested, please feel free to come up and pick up hard copies when we're done. So I'd like to introduce Kim Vanderwoord and her colleague Elaine Vlahacki, who are going to come and present the findings from the evaluation.
Good afternoon, everyone. It's a very big honor for Elaine and I to have an opportunity to share the findings with you today for the work that we had done this summer. We're gonna talk to you about the community engagement working group, community level, community-led evaluation that we worked on this summer. So the purpose of our evaluation was to look at a process evaluation, so looking at the design and delivery of the STOP project, to gather stories and narratives about the STOP project, to identify lessons learned, and then to make recommendations about sustainability planning. So as Evan mentioned, we were not looking at the patient experience. That work has been gathered elsewhere. So to guide our evaluation, we engaged in a literature review, and one of the first things that we noticed in that review was that there's obviously no one-size-fits-all for community engagement, but the information that we looked at formed itself into 3 different phases. So the first phase was what you can do prior to community engagement. So the literature talked about gaining entry into a community and getting to know the community itself. And then the next phase talked about what you need to do for community engagement to occur. So the literature talked about bringing the community together, forming advisory committees, and other things you can do. The third phase was what can you do for community engagement to be successful. So they emphasized the importance of early engagement in the process, having meaningful engagement, and developing community capacity, as well as respecting the diversity that exists within communities. So what we found was that most of the information around community engagement in HIV/AIDS work, it existed on the international scale. There was actually there was very little work or literature about this in Canada. So we thought this was an interesting contribution to that knowledge area. So in the summer, we may have talked to some of you in the room. We had 2 target groups that we worked with. The first group was case study interviews. So the people that we wanted to interview were members, executive directors, and program managers from the Pacific AIDS Network and Red Road. So we identified a total of 36 potential individuals to talk to, and our goal was to talk to 3 individuals per health authority, hoping that we would have 18 interviews completed, including people from the Provincial Health Services Authority as one of the health authorities. So we had a very good reception, which was quite remarkable in the summer. We had 26 interviews completed at the end of our interview time. And the really interesting thing that we found, by the 26th interview, we hadn't reached a saturation point. We were hearing different information with every interview. And people were, like the interview could take 21 minutes, but it took anywhere from 21 minutes to 100 minutes. And the average time per interview was 53 minutes. So our impression of the interviews that people were really passionate about the work of STOP and as well the work of their own organization. So the other group that we talked to, maybe virtually, was we launched an online survey, and that was given to frontline workers in aid service organizations and community-based organizations, again, members of PAN and Red Road. We had 57 people complete the online survey, and once we had finished gathering our data, we had a wealth of information. We had hundreds of pages of data to sift through on my patio in the summer. And we had, again, we didn't have that saturation point with the information we had gathered, so there was an enormous diversity in responses. So being able to roll up these points into something concise was a challenge. So that's probably why our report was 81 pages, but we wanted to reflect the diversity of comments. So when we were looking at the information, we were able to look at whether an individual is from a pilot region or a non-pilot region. Janice had talked about the fact that STOP had permeated beyond these pilot regions. People were really picking up the work of STOP outside. So we were able to look at it from pilot and non-pilot region, and in the report, which is at the front table, whenever we mentioned that there was a difference between pilot and non-pilot region, there was a difference. But if there's no reference to a difference between them, that means none existed. We also were able to look at the difference between Aboriginal and non-Aboriginal organizations, and that is listed as well when it happened. So this chart represents the response rate by region for both the interview and the survey. The yellow bars represent the interview and the blue bars represent the survey. So with the yellow bars, again, we had 26 interviews completed. 10 were from pilot regions, 16 from non-pilot. 8 of the interviews were from Aboriginal organizations. For Vancouver Island, there were 6 agencies identified, and we were able to talk to every single agency on Vancouver Island. In Fraser, we were able to talk to 3 of the 7 agencies. In Northern, we were able to talk to 4 of the 9 agencies. There was robust Aboriginal participation in the online survey as well. I think we had 98% of the programs who responded saying that they actually have specific programming for Aboriginal organizations.
So I will guide us through some of the findings now. To first frame the context for the findings we'll be discussing today, it's first important to talk about the funding from STOP. So most interview respondents that we spoke to did not receive funding from STOP, and the majority of these folks were from non-pilot regions. The majority of survey respondents reported receiving funding from STOP and also program support from one or more STOP pilot project partners, and most of them were from organization within pilot regions. So the evaluation also looked at awareness about STOP amongst these participants. All of the interview respondents and the majority of the survey respondents were aware of the STOP pilot project in general. They'd received information about STOP through the Pacific AIDS Network and other organizations like this across the province, through meetings and presentations, through committees, and also through word of mouth. So a quote from one of our evaluation participants is on this slide here, and I'll read it for you. Being involved with PAN, they keep me well informed about what is going on provincially and what I should be concerned about. They give the provincial response of what is going on outside of my own community. The communication is great information from PAN. So interview and survey data also looked at the consistency of STOP's goals in relation to organizational needs. Most evaluation participants reported that STOP's goals were consistent with their organizational needs overall, and in specific ways. First, in terms of having that prevention focus, and also increasing awareness and access to testing. However, they also spoke of ways that they were inconsistent, including having that top-down approach, having a lack of focus on the social determinants of health, and also the limited scope of the goals overall. Evaluation participants also went beyond talking about the consistency of the goals. Survey respondents noted that organizations in the pilot regions identified more gaps in services in place to achieve these goals, whereas those respondents from the non-pilot community didn't notice these quite as much. So in terms of STOP's activities, most evaluation participants reported at least some familiarity with these. When asked how these activities were consistent, they responded that there was this common focus on testing and treatment. When asked how they were inconsistent, they noted that there is this lack of funding and human resources to do the work of STOP, and also a lack of consultation with community. Finally, not enough of that emphasis on the continuum of care for HIV services to be provided. So we also asked evaluation participants about community engagement surrounding STOP. Interview respondents from the non-pilot regions experienced minimal, if any, community engagement with the STOP partners, but those who did have engagement said it was of good or high quality. In comparison, survey respondents were generally satisfied with the community engagement that did occur. The community engagement process in VCH is likely a large part of this. Interviewees had mixed responses on whether STOP partners listened to community members' voices throughout the project. Most evaluation participants from pilot regions said that STOP listened to community voices, whereas evaluation participants from non-pilot regions often reported that community engagement improved over time. In terms of listening to community organizations' voice, the majority of interview respondents said that voices of ASOs and CBOs were heard, noting how they were engaged and the positive implications of this engagement. In terms of how to improve communication and community engagement, there were a number of suggestions provided. These suggestions fell into 6 main categories, which included target groups, including Aboriginal people and people living with HIV, content, having project updates about STOP, communication methods, including mass media and email communication, having a strategic engagement plan for community engagement, and also time in the project actually for community engagement to occur. It's important to note that survey respondents also found that meaningful consultation was very important.
So as part of a process evaluation, we were looking at the design and delivery of STOP. And we talked about satisfaction, and with our participants, there were varying levels of satisfaction. They were asked to consider about the program's strengths, and some of the strengths that they identified were the foci for STOP, the goals, and the inclusion of peers. In terms of the delivery, people were had a lot to say about the nurse outreach teams, the fact that STOP improved access to clinics and raising awareness. And then in terms of the design and delivery being effective to achieve the goals, again, there were very mixed responses on whether the design and delivery was effective to achieve the goals. People talked about it being possibly too early to tell. They again mentioned some positive attributes about the design and delivery. In particular, they talked again about the nurses.
So this evaluation also looked at some outcomes, including the organizational impact of STOP. So the majority of evaluation participants reported that STOP did have some positive effects on their organization. Within pilot regions, it was interesting. They reported shifts in tangible program delivery, whereas non-pilot region organizations reported shifts more in a strategic approach sense. So shifts in organizational programming included increased access to testing and treatment, added programs, and more human resources. A couple of questions were also asked about STOP sustainability. Interview respondents had suggestions for improving the STOP goals framework, which fell under a couple of categories, which included the design, so looking at focus on more prevention, education, and stigma reduction, looking at delivery, and aiming for better strategies for rural access, and approach, aiming for a bottom-up approach, including voices of people on the front line, and communication surrounding better access to information about STOP. So when participants were asked what the provincial expansion of STOP would mean for their organizations, the majority indicated that they would prioritize the STOP goals, many noting that they've actually already done so in their practice. They also noted that there would be implications for their practice to meet the STOP goals, namely increased funding for staff, outreach workers, organizational support, and challenges surrounding testing in rural regions. Overall, half of the evaluation participants reported that they do currently have the resources to do the work of STOP, but this was largely due to STOP funding. And others indicated that they don't have these resources, needing more staff and funding to do the work.
So we were also able to talk to participants about lessons learned, and they identified a couple of other challenges in terms of having the organizational development and capacity to do the work, as well as confidentiality around continuity of care. We asked about what the most important outcomes were for organizations, for their organizations, and they said that STOP had widened their scope of practice, helped improve their care, and engage new clients. So we had a number of, based on the information that we gathered, we had a number of suggestions for moving forward. And one was to revise the STOP framework to include best practices in community engagement and findings from this evaluation. Also to improve transparency and communication. That was the feedback we were getting from participants, but it's also something that's identified in the literature. Including meaningful engagement. We talked earlier about having communities involved early and having the right communities involved. And we also talked about broadening the approach to include community engagement. In the planning phase, ensure that there's enough funding in place to resource the ASOs and CBOs who conduct the work. Ensuring that there's capacity within the organization to carry out the work, and then finally to disseminate the findings in settings like this, having an opportunity to share the lessons learned and the success stories. So thank you for having us.
Thank you so much. Thank you, guys. I'm sorry to hurry you along a little bit. I just really want people to be able to hear from the community partners. Does anybody have any questions specific about the evaluation? So sort of the methods used specific for the team here. If you could hold your kind of overall general comments to community to the panel, which I'll introduce first, but more around the methods of the questionnaire and that process. If you could come to the mic, Trevor, sorry, just because it's being filmed.
Hi, I'm Trevor Cornell from Interior Health. So I am wondering, I'm assuming a portion of this was qualitative, so I'm wondering actually if you had some really helpful quotes that you could, even one or two, just provide us. So that can speak volumes.
We have many helpful quotes, and I'm randomly opening the report to a page, and the part that I'm looking at is listening to the community member's voice, and they talked about having a mixed response in the quality of how STOP listened. So a couple of the quotes in that area. talking about, yes, I think now it was a bit of a struggle, but I did not believe that at the beginning. They were talking about how at the beginning the communication wasn't very good, but it improved later. One of the quotes that we had, actually in our presentation, but we skipped, was, we had to shake the tree hard in the beginning to engage with STOP, saying Aboriginal people need to be engaged in this. It took a little while, but I think they have. And then another quote, I definitely think so. That is something that STOP program has done. As much as we have experts, the client is the expert. We need to listen to them for what we need to achieve. In this community, their voices have been heard. There's, in the full version of the report, there's a lot of amazing quotes. Again, people were so passionate about this work and had so many insights into how this all rolled out. Thanks, Trevor.
Just again, the copy of the reports are right here in front of Lynn on the table, and there's also this executive summary, which is excellent and really beautifully presented. So thank you so much for your time, and hopefully they're also here for questions afterwards, or perhaps some might come up during the panel. So I'm very excited to next present my colleague Miranda Compton of the famous M&M. Her and I, people often mix us up. Sometimes people yell at me about something I said and say, that Megan promised me this. And they don't realize they're talking to me. It's quite fun. But I'm going to bring up Miranda. So Miranda was founder of the AIDS Vancouver Case Management Program, so comes to us from community and has crossed to the dark side of health bureaucracy and is now with Vancouver Coastal Health as the HIV/AIDS manager. So she's the manager of the Stop HIV/AIDS outreach team, this infamous team of nurses you keep hearing about. And she also is a manager of many of the contracts with the community agencies. So we thought she'd be perfectly positioned to speak to some of this work that we're talking about. And then I'll introduce the panel after Miranda's done.
Okay, I'm going to try and burn through these slides quickly. So it'll be a very brief overview because I really want to get to the panel, which will be the rich part of our discussion. But this was a really exciting opportunity for me at this point in my career because I've spent so much time in community and then a few years as a contract manager, sort of in the long-time traditional model of contract management, health authority to community. And the STOP project gave us an opportunity to completely innovate and turn that model upside down. And so we tried as much as possible to do that, and the journey continues thanks to the sustainable funding. Oh, other way. Okay, so you've seen this slide before, but this just sort of, this expanded chronic disease model has really informed a lot of our planning work, and particularly what we like about it is it really illustrates the importance of community and a strong community as part of a strong and comprehensive system of care for people with HIV. So that really dictates a lot of how we've approached this. So right out of the gate, in the very first month of the project, we realized we needed to connect with community and hosted a community stakeholder information session. At that point, we didn't know really where we were going with the project, but just immediately knew the need to engage with community. And from that session, a steering committee with key community representatives was formed, and that steering committee met regularly through the first, I'd say, 18 months of the project as we were making decisions about funding and how we would embark on this, very daunting and complex journey together to increase access to testing and treatment engagement. And we also hosted meetings that brought the community back together at 6-month intervals throughout the life of the project. And you see a little timeline at the bottom of the slide there, probably difficult to read. But those sessions morphed from sort of information sharing and getting feedback around planning to report backs where communities were able to, community agencies were able to report back on their successes and what they were achieving and where they were going with their projects. Starting with the project, we've mentioned before in other presentations that a very vital first step was doing a comprehensive literature review, and we contracted with Dr. Sarah Fielden, who's here today, to do that for us, and that informed a lot of our early funding decisions. And then we also, of course, reviewed the current HIV/AIDS epidemiology and treatment utilization data for our region, also extremely important. And we had a session that again brought community together, where we together completed a client process mapping that looked at the client experience through the healthcare system for different client populations. And this really assisted us in identifying where the gaps were in our current system. And at that same session, we did sort of a current state overview, and Megan prepared a very comprehensive presentation on that, and did a bit of a SWOT analysis, strengths, weaknesses, opportunities. And so these early meetings really informed how we were going to go about this. And all of this, this thing is, yeah, that'd be great. I'm left-handed, and this is my right hand, and it doesn't operate. Yeah. Thank you. I'll go. So you've also seen this. We have it as a handout because it's very hard to read, but we've been populating this sort of client journey as we've gone along, and this is going to inform a lot of our work going forward. We're trying to sort of make sure that we're taking into account every component that needs to be in a comprehensive system of care for people at risk as well as people living with HIV. Go ahead. We took the approach of expanding capacity, which is, I think the words are important because we really took the philosophy that we're not looking to create something shiny and new, but really to build on the resources and services that are already in place, while still looking at the gaps that existed in the system and where programs and services need to be threaded together to work better. And then we also looked at the entire system of care. So we definitely worked with aid service organizations, but we also looked at other community-based organizations, most notably housing, to kind of look at where there would be good partnerships to achieve our goals. And from this work emerged sort of a whole variety of different ways we look to partner with community. So the first one was the direct service approach, which was just expanding the capacity of some existing community-based VCH services and Providence services that would benefit from expanding and to be able to reach further. And we also created the Stop Outreach team in that model, which was really with a mandate to fill a gap of working with folks in the community who were not getting independently to the services that they needed. And then we had the hybrid approach, which I love, and Doreen's here today, and she can speak to it in more detail, which was where we worked with a strong community agency that already existed, and my example here is Vancouver Native Health, and asked them what they needed. And they already had a strong clinical program, but they told us that it would be incredibly helpful to expand that clinical model, and so we gave them Vancouver Coastal Health nurses to work alongside their existing clinical staff. And that was a new way of working, sort of two agencies, matrix reporting. Doreen and I had to work really closely together because we were overseeing this similar staff, but it was a really rich and a great partnership, and one that we're looking forward to continuing and expanding. Then we had the more traditional contract relationship where a community agency had a good program that we sort of envisioned together, and then they were given full jurisdiction to develop it. And an example of that is what you've heard a lot about them over the past 2 days, the Positive Living BC peer program, who became part of our circle of care, but were autonomously looking after overseeing their program. And then we have the host program, which is where there would be a community agency that didn't have a clinical component in their services, but very much wanted that and wanted to sort of see what that would look like for their, and it was a way for us to get clinical services to folks in a place, to folks who may not be going to traditional mainstream clinical services. So an example of that is the Downtown Eastside Women's Center, who had wanted for years to have a nursing program for their staff, for their clients, and we were able to provide a 5-day-a-week nursing clinic. So that was great. They had BCCDC in there once a week, and so we were able to work in partnership with BCCDC to expand that nursing role. And we also worked, another example is a health initiative for men. We together developed a satellite clinic to provide an East Side sexual health clinic for men. Next slide. And so here's a picture of one of our wonderful partnerships, and Jesse's here today, and doesn't he look great in this photo? This is our No On The Go mobile testing van, which is a van that we take all around the city to different venues, festivals, parks, and bars. This, I think, where are you here, Jesse?
We're outside the junction, which is on Davie Street. Butte.
Outside the junction on Davie Street, providing sexual health on the go. And here's another of our partnership with, a picture of our partnership with YouthCo, which is, Scott made mention of it earlier, that we were able for the first time to offer testing and sexual health information at Pride. And there's Scott in the photo, as well as Megan, looking good. So one of the things we did that was also different is, and you maybe heard this before, I think Chris mentioned it yesterday, is that all of the, we call them memorandum of understandings, all of these pilot contracts were set up in 7-month contracts with a really sort of very focused set of standardized deliverables. And it was a little bit of an administrative nightmare for the contract manager to have 7-month MOUs, as well as the contract, as well as the community agencies themselves were sort of balked at this. But we only know we have these resources in place for 6 months. So we struggled through that together, but there were benefits to that. 5 minutes, okay. There were benefits to that in that we're able to keep the dialogue going about what was working, what wasn't working throughout the project. We had to, because we only had 6 months to sort of figure out if this was going in the right direction. And so it held us both to a very high standard of accountability and forced us to really stay in close communication with each other. You may have also seen this slide too, but our project team put together a rigorous performance measurement system that involved, tracking the data very carefully. And the one good thing is that a lot of the community agencies were sort of like, we don't have the tools to collect this data at all. We don't have the systems. We don't have the administrative support. The project team was vital in coming in and saying, okay, well, what do you need? This is what we would like you to collect. What do you need? And how can we help you achieve that? And so I think, if most people would say that this was really helpful to them because they were able to utilize these like clinical analyst services to really strengthen their system of care. So the strengths of this system, this whole approach, was that we were able to work together with community agencies around common goals and vision. We were able to capitalize on the skills and expertise of community agencies toward meeting the overall STOP goals, and it felt really great to do that. We were able to feel like we were in it together, look at the collective impacts, increase integration. I kept saying, we may not know if the funding is going to continue, but what we will have is that we've threaded our efforts together so much more closely, and that is something that will continue, money or no money. And so I think, it's great that the money's continuing, but that's definitely a sustaining piece. And we were able to, and then also the tight MOU periods gave us a chance to really make adjustments in real time as they occurred. So for almost across the board, every single project we implemented, the vision, our collective vision was very different from in reality once it was implemented what happened. And we were able to just shift with that and make changes and have discussions about why that was. And so it was this endless learning opportunity. Some of the challenges were that, it's already been mentioned, but we struggled with confidentiality and privacy and continuity of care issues. Sometimes our strict mandate, we called it the stop box that we were stuck in, that everything we had to be directly related to increased testing and access to services, made us collectively feel quite constrained. And then communications, this was also mentioned in the feedback, and I feel it as well, that there was so much happening. We were implementing projects on an ongoing basis, and it was just really challenging to carve out the resources to keep the community up to date, and really to know what the mechanisms would be, what would be the most effective mechanisms to do that. So that's an ongoing learning opportunity, and we look forward to feedback from community about how we can improve that. So lessons learned. We started with the knowing our epidemiology for the area. That was so key. Understanding our current state, where were the gaps in services, where were the strengths. Establishing a common care delivery model, and that's that client journey that you saw in the previous slide, was really helpful in kind of getting us all on the same page about what programs and services we should develop. And then having this new funding is sort of this golden opportunity for those in the field that have been in the field for many years. It's sort of a dream come true to have some new resources to really innovate and do some new stuff with community partnerships. So that's been great. And here's just an example of one of those innovations, our PHS peer test. This is our peer testing project that we did in partnership with the Portland Hotel Society. And I have a handout that describes briefly all of our projects, so you can come pick that up. And if you want to know any more about any of them, contact Megan or I. And just, we looked at non-traditional partners, and that was really important, including private for-profit agencies such as bathhouses. We partnered with churches to do testing events and food with their food programs, sports events. We also worked, it was also really important for us to work with cultural consultants for communities that we needed some link into and someone to assist us in connecting with. So we continue to work with some key people in the South Asian population to increase access to testing in that population and with our Aboriginal partners. And we had a great innovation project with one of the Latin American community advocates, who many of you know, came to us and said, I think we really need to be testing the Latin American drug dealers in the downtown east side, and I know a former dealer who would really love to be involved in a project that helped you access and connect with those guys. And so we currently have a project going where we are on a mobile basis testing and connecting with those folks. So that's just some examples of innovation. Here's a picture of our tiny little clinic that's in one of the houses that really was championed and implemented by Stephen, the nurse that you see in this photograph. This is another bathhouse photo, just quickly to small things that just by going to the bathhouse, Stephen noticed that they had one big dispenser of condoms at the entrance and then no place to access condoms once you'd entered the bathhouse. And so he talked with bathhouse owners, and together they got these little baskets of condoms throughout the space. And they even got them to change the lighting so that there's now a spotlight on the condoms. And then right next to his gigantic Get Tested poster that he puts up just when he's there. So it's just little things that gave us new opportunities. So engage partners early and seek their input, establish common goals, and provide support for, and provide your community agencies with support for monitoring and evaluation, so key. And I think that's it.
Awesome. Thank you so much to all three presenters for tolerating me cracking the whip there. I really appreciate it, and I hate cutting people off, but I'm really excited to hear from our community partners as well. So I'd like to introduce them now, and a little funny anecdote that Chris just reminded me is that it's interesting, there's actually three former and or current executive directors of YouthCo on the panel. So we've got Chris, Kevin, and the current director, and we have a board member in the room. So I feel not our only community partner. Yeah, there we go. That's pretty fun. So without that, I guess I'll start with Jessie. Jessie Brown is the Executive Director of YouthCo, an organization that works to reduce the impact of HIV and hepatitis C on young people in British Columbia. STOP and YouthCo have partnered on two projects. One is Know on the Go that Miranda mentioned, and the other is Get Connected, which is a peer education and support project for youth living with perinatally acquired HIV. And next to Jessie is Doreen. So Doreen Littlejohn, hopefully known to many of you in the room. She was formerly the nurse coordinator for the Positive Outlook program at Vancouver Native Health Society from 97 to 2012, a highly successful program that provides care, treatment, and support for up to 1,500 HIV positive members. Doreen is involved in the Southern Leadership Committee representative for the Aboriginal community and is also a member of the ARC. She was also a member of the Stop Community Engagement Working Groups, and she's now employed by the University of BC at the School of Nursing as the Intervention Coordinator for the Aboriginal Women's Intervention Research Study. Thanks, Doreen. So we all know Miranda, and I've got to still introduce Chris. Do I need to introduce Chris? Is everyone in the room? Chris Buckner. my former boss and colleague, Regional Director of Prevention for Vancouver Coastal Health Authority, and as you know, it has a long history in the HIV/AIDS movement and in Vancouver. Thanks so much. So my first question to the panel, I'm going to do this as a bit of an Oprah style to get us started, but then I'd really like to hear comments from the room as well. So the first question I'm going to ask the panel to reflect on is, can you describe for the room some of your greatest successes and challenges in terms of community engagement with the STOP project? And when you answer, if I could get you to use the mic. I see Doreen's ready to start, because we are being filmed, and that way this can be preserved for forever.
I always have lots to say. I'm especially passionate about Aboriginal community and working with people with HIV. So I have no shortage. When Miranda said her quote, "It was like a dream come true," I can attest to that dream come true. With the work that we did at Vancouver Native Health with Vancouver Coastal Health, it was a dream come true. For many, many years, we had struggled with funding. We struggled with the most marginalized population, I think, in Canada, living with HIV and AIDS. When I first started at Native Health, our death rate was 10%, which is the same as sub-Saharan Africa. We were caring for people. People were dying. They had end-stage AIDS. We never had enough time. We never had enough resources. Our funding was always at a lower level as we were a contracted agency. But we managed to keep on going. And we were building an amazing place where people were connecting. And when you're working with Aboriginal communities, it's about relationship and it's about trust. And trust and relationship, of course, take a long time to build. You also have to have stable staffing. You have to know your clients' stories and work within the context of their stories. So when Stop AIDS was formed, we went to Vancouver Coastal and we explained our model of healthcare, which they knew because they were a funder of ours. And we had a program that was called Towards Aboriginal Health and Healing. And it was a very intensive case management model for the most marginalized Aboriginal clients. These were 20 clients that were engaged in this program that were all going to die. None of them were taking medications. It took in some cases up to 2 years to get these people to agree to take medications. All had tremendous problems with substance use. You name it, they had it. And so we had this model, and it had an elder, had 4 peers, a nurse, and a social worker, and Health Canada had funded it. But in 2010, Health Canada withdrew funding for all community AIDS projects. So I went to the Stop AIDS Committee, and I put a proposal in, and they funded our program. Amazing. They also funded nurses to come to Native Health, a social worker. We had 1,500 HIV clients, and we never had a social worker at Vancouver Native Health. They funded MOAs. They funded a primary health care physician. So we had this incredible team, and all of these resources come our way, and then we also had the contracts that we had to manage. And as Miranda said, they were painful. But what it did for Vancouver Native Health, it made us look at our program delivery model. It made us look at what we were doing. It made us look at our outcomes. We had help from Danielle. Was it Danielle that helped us put all of our forms together? We actually got an electronic data medical base called OSCAR, and we developed an HIV/AIDS flow sheet. We also were able then to look at our outcomes, to look at our viral loads, to look at our viral load suppression, to look at our people that were taking ARVs, to track their progress, to look at people who were getting their flu shots, getting their pap tests, getting their TB testing, to look at when they were coming in for primary care visits, when their blood work was due. So clinically, we were able to organize and look at goals that we could set to look at clinical excellence and not have our people fall through the cracks. So for us, it was outstanding. Were there problems? Of course. Were there successes? Huge. Were there lessons learned? Yes. And I certainly think there's knowledge keepers in our system. We don't have everything written down, but what we do have is people that can share the common knowledge of this journey to help roll this out in other communities. I think I'll stop there.
Thank you so much, Doreen.
Hi. Yeah, I think for challenges and successes, I just would echo everything that was pretty much in the report, the great report that was done by Kim and Elaine and Evan. Because yeah, one of the best pieces I think about working with STOP was the nurse outreach team and the wonderful work that they're doing, going out in the community, doing really frontline stuff and connecting people back with care, which was evident at YouthCo, having Jeff Ford come in twice a month at the Breakfast Club and engaging with people that might not normally go to a regular clinic. So that was a great success. I came in about halfway through the STOP project in my role at YouthCo now, and we hadn't received any funding from STOP. So I went out and Miranda came actually to YouthCo, and we had a meeting about some different projects that might work for YouthCo. And so I think also the communication with the STOP contract managers too was a success of the project. Yeah, and I think challenges coming in a bit late in the game and sort of scrambling, it felt a little bit to get a piece of the pie maybe was a challenge, but I think ultimately it resulted in some really fun and innovative projects at YouthCo that we definitely wouldn't have been able to do without STOP. So.
Great, thanks. Anybody else have a comment on challenges? Any questions coming up from the audience? Anybody? Anything specific? Thanks, come forward.
Thank you very much to all of you. I really appreciated listening to this. I'm Leslie, evaluated with Northern Health. And one of the things that Northern Health struggled with, or as part of the learning process really, in developing understandings with their community partners, is just relationships. And so Miranda, you talk about developing 7-month contracts. I'm not sure why it was 7 months.
I don't know either. Chris will. No, there's a bit of a rationale.
Were you able to negotiate those MOUs fairly quickly? Like, was it based on previous relationships that you had already with your community partners, or were you starting from scratch?
All of the above, actually. I mean, it was, so to begin with, the 7 months was because we thought 6 months is half a year, and so that would be because we wanted to keep it short to sort of keep the dialogue going and keep close eye on that. Is this getting the results that we had intended and need? And I mean, we also knew that we were under great scrutiny from the Minister of Health to, be achieving results. So, so it was for that reason, 6 months that gives, and 7 months was because we had 1 month to figure out, are we continuing or not? So we'll look at 6 months of data and then 1 month but it was arduous. And towards the end of the project, I think last fall, we just said, okay, everybody who's been working really well gets till March 31st. And so we stepped out of that. But for the first year and a half, we were tightly in that. Yeah. And then in terms of, we worked with new partners. I mean, Positive Living is a provincially funded organization, and so that was new for us to work with them, and it was new for them to do something that was Vancouver-based, because they have a regional mandate. So to do that kind of one-to-one support work was also new for them. So I would say that that's one of the new ones. Then we also our bathhouse partnership that I mentioned, and some of the housing partnerships. We worked with our housing partners in a new way, and certainly HIV hadn't funded housing projects in this way. So there's quite a few, but it was under that whole thing, like try something new. And just building on what Jesse was talking about when we had that meeting, I mean, it was this great brainstorming meeting, because Youth Co didn't want hundreds of thousands of dollars. They actually, I think you said, you wanted like small things, but that would have a big impact. So one of the things we talked about, we found that we both had a passion for sort of this underserved and forgotten, but very small population of children with, or youth with perinatally acquired HIV that is, there are no services for. And so we, in that conversation, both got really excited about things that Youth Co could do. And then it was a very small amount of funding, but how great to create a community-based services for a population for whom nobody had created a community-based service before. So stuff like that.
So it sounds like there was, sort of like it was fairly, maybe building trust was that like a big issue, or?
I mean,
With some, I'm not
when
saying
there's
across the
resources
board.
on the table, it's amazing how much quicker you can get to trust.
Yeah.
I mean, that's it. And Chris can
Chris
speak
has
more.
Thanks.
Well,
Brenda.
just really briefly, and just because feel like I've been talking a lot over the last couple of days, I'm going to try and be brief. But it's hard for an organization like a health authority that has so much invested in kind of the structural power that it has over other organizations to go through a process of saying, acknowledging that that relationship doesn't work. It's really difficult to go from a place of seeing advocacy that community-based organizations are doing, and thank God they're doing it, and try and turn around from seeing that as something that makes my day really crappy to have to deal with as a bureaucrat, to actually go to the place and say, from the broader scale, this is something that moves us all forward in terms of our common goal. So I'm not saying for a second that VCH has done a fabulous job of trying to change that dynamic. But it is something that some of us are trying to intentionally work on and say, we all play a role in delivering services. We have a common goal, and we all play a role in delivering these services. And health authorities do some things well, and kind of concept of core competencies, and they do some things really poorly. And it's a strength to recognize what you can and cannot do, and it's challenging, but we've got to try and do it, to open up and say, who can do this better than we can do, and how can we work together in a better way? And so this is something that we're trying to learn to do better, and I think it's a marathon, it's not a sprint, but I think there's a lot of value in that, in just kind of having the courage to sit down with partners and say, what role do we play? Who's got which core competency, and how can we collaborate effectively to meet that goal? So that's in terms of a bit of a barrier thing that I think, I don't know, maybe people who work in other health authorities can relate to a greater or lesser degree.
I think just to touch on what you were saying, Chris, the Know and the Go project is a really good example of recognizing just the skills of the Vancouver Coastal Health and the STOP team, and then also what Youth Co does best, which is the education and outreach piece, and combining those two things into a really unique project that happened quite quickly, because we were able to, buy a van in a week and hire a coordinator in a week almost as well. But then also knowing that we had the really skilled STOP outreach team who are able to provide that quality service, it just made me feel a lot more confident about the project that we were doing.
Thanks so much, Jesse. And Evan has a comment, I think.
Yeah, I just wanted to pick up on that theme, and just also based on the community evaluation of STOP, I think a really consistent theme from the community-based organizations was that they did really appreciate that, that there were additional resources being put on the table, and that this was kind of a really unique opportunity in the sense to actually be creative and to be a bit more nimble and to try things. And I definitely, I think that there was a sense that health authority was willing to kind of go along with the ride a bit. I mean, I think there was, I would hear from other executive directors a certain amount of moaning about the 7-month contracts, because it's really hard to also, it puts a considerable burden on a community-based organization to administer those, and to, you know, it definitely begs the question of sustainability. So I'm not necessarily sure if that necessarily is the best model to continue with, but I think like emphasizing, particularly for the new regions, emphasizing, you know, there is this ability or potential ability to try some new things, and just to be creative. I mean, it is really an exciting opportunity, and that there actually is going to continue to be more resources available and now for the rest of the province. So it's quite exciting, and I think overall, like when you look at the voices of the, you know, the community in the evaluation report, there's a tremendous amount of enthusiasm for STOP. Like it really did, I think, excite people and galvanize people. And also, I think the other incredible thing about that it is going to be a provincial expansion is this opportunity for shared learnings. And that's why I'm so appreciative that there is this event that's happened, primarily, you know, mostly with health authority folk, but for that opportunity to learn from the pilot regions, and also for community organizations to learn from each other as well. And again, this theme keeps coming up over and over again, you know, not to reinvent the wheel. So I think there's this incredible opportunity. And also, I think the other thing that I wanted to just say too is I think that it's kind of an era of shared and mutual accountability. And maybe that kind of touches on what Chris said too, that there's things that the health authority does well, and there's some pretty amazing things that the community does really well. And that really we saw that kind of growing spirit of, you know, mutual respect and appreciation for each other. So I really hope that we can keep building on that momentum as we have this provincial rollout.
Thanks very much, Evan. Is there a new question from the audience? Come on up to the mic. Jamie Forrest.
Hi, everyone. Jamie Forrest from, I'll say YouthCo first, because I'm at a community event. Board of Directors of YouthCo and the BC Center for Excellence in HIV and AIDS. My question is that there's a lot of really great talk about the synergy of the contracts and the negotiations that happen. How, when you're creating your markers of success and endpoints for successful contracts, how do you standardize those when there's such contextual differences between the types of community partners that you're engaging with?
Excellent. Researchy question. I'll take a stab at it. I don't know, Megan, you might be even, anyway, I'll take a stab. I mean,
And Oprah. I don't know what you're talking
at the purest level, and this is changing with Hope to Health, it's broadened, so that creates an opportunity and also adds complexity. But at the, you know, we knew that we were ultimately getting evaluated on number of tests and number of people engaged in care, and the best marker for that is their up-to-date blood work showing reduced viral load, increased CD4 count. So you know, none of us, you know, ever, I think, got to a place of feeling wholly comfortable with that, and yet I think we made it work because it creates a dialogue, even if, you know, not many tests are happening. And at the Downtown Eastside Women's Center, quite surprisingly, we really struggle to have uptake of testing, but that creates a dialogue. Why is that? You know, why are women so reluctant to test? So I think that we tried not to make those targets a daunting thing, but more a dialogue piece. And then, you know, I should say that, but there were some projects that we did have to sort of come to a decision that, you know, we wouldn't continue with because they were not quite meeting our very strict box of accountability. But I think because we were very transparent about that from the get-go, while it wasn't a fun meeting, I think there was understanding throughout the process that this might happen. So that might not fully, fully answer your question. And we had crazy targets too. We set really unrealistic targets for our satellite clinic on Commercial Drive that we did with the Health Initiative for Men. Thinking that, one nurse could test 4 guys per hour and times 4 hours, and so times how many days a month. And I mean, they didn't get anywhere near that. But I mean, that's partly it's a new service, and actually, it's not good practice to only spend 15 minutes with somebody who may have have a lot of risk they want to talk about or many questions. So that's not even sort of we realized that's not really our goal, you know, so, but then only by implementing the service, then we, you know, could say, well, this is what we found out. We actually, two clients per hour is actually the ideal for this clinic.
Yeah, for me too, it was a partnership. Like you've heard a few times now, if you are a health policy person or a health authority person in the room, you have to have. You've heard us talk about our STOP project team and our analysts, and the words Danielle and Lindsay and Lynn sitting right here, and we couldn't have done this without them. And they would come hand in hand with us, because it was sort of Miranda and Chris and I who had the relationships, but we'd have someone from the project team with us to really talk about how to do the evaluation and develop tools. And Danielle was also, I think, quite skilled at saying, what would you like to know about your service? What indicators would you like to collect? So there was sort of the hardcore CD4 and viral load of everyone in the program before and after was pretty sort of in almost every treatment or support program. But then there was also, what do you want to know? Like, you want to know about access to housing pre-post the intervention. You want to know about addictions treatment before and after. And some of us Evan and I were both on a social determinants of health subcommittee of the STOP evaluation, and it was like constantly trying to pressure and find these common indicators for those determinants of health. And we never quite got there, but we slowly did learn. I learned that viral loads can be a huge advocacy tool for housing. You know,
Yes.
there's now randomized control trials showing that is one of the most important things that actually impact viral suppression. And that's actually really useful as someone that's always known that intrinsically in my work, anecdotally. And so for our housing pilot, we were able to show pre-post that people's viral loads, that was absolutely a huge measurable, and it was really rewarding to see that.
Yeah.
It was like, wow, actually, so you can start to sort of manipulate
I mean,
these
and-
biological markers to show what we've always known in our hearts.
And that actually created a great tool for that particular partnership where the housing provider was at one point sort of wondering, what did we sign up for? You know, the clients you're sending us are among our, you know, most complex, and they're taking up a lot of our staff time, and you know, but then we were able to say, you know, but overall, like we had this amazing data that, you know, people's viral loads had, we went from 23% with a suppressed viral load on intake to 86% 6 months, and you know, so and then, you know, their jaws dropped. I mean, and that they were, you know, amid all this chaos that was happening for the clients, the clients, their residents their health was improving, and we had really great data to share with them around that. So, so that, you know, that really helped the partnership. They became, you know, then became like the, you know, one of the feathers in their cap that people's health was so demonstratively improving as a result of that partnership. So.
Doreen, did I see you with your hand up? No? Great. I'm going to maybe ask a bit of a tough question, and my colleagues might kill me, but around privacy. So we're talking a lot about data, but I've heard this come up in our smaller group. So how did you guys handle some of the obvious sort of privacy and confidentiality concerns of really working together as the health sector and community? Jesse?
Yeah, well, we haven't had too many challenges with that, just to be honest, although we are in a van out in the middle of the street doing testing. That said, you know, all of YouthCo staff have had signed confidentiality agreements, and we take it really, really seriously, obviously, and I know that the STOP outreach team also has had training and take confidentiality very seriously as well. So I think just a sort of environment of a lot of respect around that, and wanting to make sure that clients accessing a unique service like Know in the Go are going through the pre-testing screening, and knowing that if we're at a party or something, we're not going to do any testing on anyone who's been drinking or issues like that might arise, and yeah, just being very sensitive to issues around that, so that we're not putting anyone in a situation where their confidentiality around an HIV status may be at risk.
Thanks, Jesse.
Do you want to say anything about it?
Confidentiality, of course, at Vancouver Native Health is ironclad. And when it came to testing, we weren't involved as much in this big community testing as other organizations were. We certainly had nurses from the BC CDC come to Vancouver Native Health and augment our testing at our women's clinic. And again, it was offered completely confidential in a closed room between the nurse and the woman participant, along with lots of pre- and post-test counseling. It's critical, and I certainly, when you say at the clinic on Commercial, they should only see 2 clients in an hour, yes. In some cases, if a person has a lot of questions, you have to expand that time. And certainly in Aboriginal communities, when we were doing testing, there's, again, that whole relationship question, the question of trust, and the need to really take your time. I can't say enough about that. And recognizing it's a different cultural approach when you are testing in that community. Some comments that came up around our HIV rounds at Vancouver Native Health. We had rounds every Thursday with St. Paul's Hospital 10C, the community stop nurses, the Vancouver Native Health team. And we are always very, very careful only to talk about our clients in common that we shared, but never to discuss any other clients that were in the testing realm. Some comments that did come up from some of the community nurses, and this did come from some of the clients early on, was there would be an alert go out into the community that so-and-so is tested positive, and all of a sudden this person's door may be knocked at a few times by various people trying to track. So again, we had to be very, very careful who we approached and how we approached and who knew. Do you want to talk about that at all, Miranda, about some of that controversy? It was. Certainly, it wasn't big. It was addressed. But these things do come up and will come up in community as again, as lessons learned.
Is there a section in the thing to talk about?
I was just going to say, I was wondering if I could just ask Kim to speak to that, because I know that was something that did come up in the community evaluation as a somewhat consistent theme around confidentiality and privacy. She's looking at me with a frown. But I will say that I mean, I do recognize too that I think there was also some concern around the whole testing in the acute care setting as well. And you know, I think it was a challenge for people in the community to get their head wrapped around that. And so I think probably one of the biggest things is to acknowledge that that'll be a concern if that's how things get rolled out in your health regions, and doing the work that's necessary. The reality of it is that there still is a lot of, I mean, not to beat on this topic, but a lot of stigma still surrounding HIV. And also, I mean, just anecdotally from my own experience, I don't want to pick on them, but being at St. Paul's, I had a very interesting experience once being in the emergency room there with a friend. And the gentleman in the little shelter area, you know, between the curtains, he was offered an HIV test. And of course, we could hear everything because you're only being separated by curtains. And my friend was not. And I think that, you know, my friend looked like me, white, middle class, you know, certain kind of lady. So I think, you know, we do need to be sensitive to those things. Other things I've heard anecdotally was that there was concern in the north that from some of the community groups, the sense of maybe like people being compelled to test, or because when you're working with so many like really vulnerable people and it's like, well, I want my meal, do I have to get this test to have my meal? So I think in terms of informed consent, there are definitely some issues there for all of us to work on wrapping our head around. Because I totally appreciate the need for for testing. And, you know, the flip side of that, I'm such a Libra, so on the other side of that, I mean, I think it has been wonderful the extent to which testing is becoming more and more normalized. But we do really need to pay attention to the other side of that, so.
I know there was an invitation to Kim, and then I want to get to Trevor too. Kim, did you want to pull anything out, or pass to Trevor while you look? Great. Maybe I'll just add one advice about the community concerns. If I could do something differently, I think I would have had forums before I launched an initiative. I mean, we were really under the gun, but in hindsight, like before the peer testing initiative, for instance, should have had a big community dialogue and heard everyone's concerns and gotten their feedback. We did it on a small scale, didn't do it big enough. I mean, that was a real mistake because the rumor mill spun out of control, and I think Chris says quite often, you know, if you don't give people the information, they'll make it up, and it won't be a good news story. And that's a big lesson. And for acute care as well, before launching it, you know, we slowly developed our communication plan and frequently asked questions documents as the questions came up, but we should have done all that beforehand. And that's, you know, you have the luxury of borrowing and stealing ours, but I wish we'd done more of that. And then my final tip is I kept saying every time I got a complaint, thank you, and would take this seriously. And if you'd like to put me in touch with the patient, you know, can you, or here is our complaints number, here is our complaints email. All of our health authorities have like privacy or complaints concerns departments, and I really wanted to empower people to make that step and to acknowledge that mistakes happen, and that sometimes, you know, maybe there was an unconfidential offering or that, you know, the process wasn't followed, and that you just can't pretend that everyone's perfect. People make mistakes, clinicians make mistakes. So just really trying to honor that those happened and that patient needs their rights to be protected and the opportunity to complain formally. Just a thought. Trevor?
So this is a bit of a broader question than BBI or aid service organizations. When you look at doing something universally, so this is not the targeted piece, but the universal, did you and Chris do any work engaging with, say, the United Way or faith-based organizations? The example for VCH would be Covenant House, you know, that sees 7,000 youth visits a year. So, and what was your experience with that? Like, is it worth doing that? And if so, how do you approach it when you are philosophically, as a secular healthcare provider, philosophically now aligned with the provider?
Do you want to tackle that, Chris? Or?
So it's kind of two questions, right?
Miranda?
I mean, I can say just regarding the Covenant, I mean, Covenant House is a good example. I mean, we did partner with the mental health outreach team that works with Covenant House, but they're actually under the auspices of Providence Healthcare, another faith-based institution. So that was our way of connecting with them without sort of, you know, partnering, implementing a program within their, you know, under their umbrella.
And I think too, the street nurses already had partnered with them, so Glenn's in the back room, but I mean, many of this, again, building on what works, the street nurses and the BCCDC, I used to work for them, have long known about partnering with community agencies, and in some ways the outreach team, the STOP outreach team had more of a treatment focus and, you know, I will acknowledge we stole their model completely of going into an existing community agency, low threshold where people already are, but we were more offering catching people up on HIV primary care as opposed to testing, so kind of hand in hand. And we usually tried never to go somewhere they already were, and we were in close contact to be working together so that we weren't duplicating our service. But we also had some partnerships with temples in the South Asian community, absolutely. One of our key partnerships we're continuing with in the GP initiative, definitely in the First Nations community, going to health fairs, and Denise and I were up in Mount Curry in partnership with Chimamuk, VCH, and First Nations Inuit, FNIB, which is now, I always get all the names mixed up, but Denise can talk about that a bit. But very worthwhile partnering also with some churches, food banks, absolutely. Anybody else?
Just wanted to speak to the partnership with FNIB, and just really appreciated STOP's ability to respond to the request from a community to have HIV testing at a wellness fair. And sometimes that can be a missed opportunity, but in this case, your ability to be flexible and creative and respond right away. I think it was about a 7-week time, not even 7 weeks from the time that it was yes after meeting you face to face, and then trusting in you and your team to then support that. So, and I say yourself in terms of Vancouver Coastal, but it was a partnership with BCCDC, Chimamuk, and FNIB. My job just being the coordination to say, here are the services already there. And we thought that was really successful as, you know, a way forward with partnering with communities that don't have the volumes as the urban setting, but looking at that as an approach. So thanks.
Just one quick comment. We've talked a lot about community-based organizations in terms of service organizations, but we're also beginning to learn things about partnering with businesses. And Miranda touched on that a little bit in terms of the experience with bathhouses and providing, doing outreach in bathhouses or HIV testing or STI testing in bathhouses is not necessarily new. But I think, you know, no secret for folks who have followed the history of HIV in North America, that the relationship between public health and bathhouses hasn't always been a great kind of combination. But it was just the time invested to work with a business was just paid off so strongly. When we visited and toured around one of the bathhouses that was hosting some of the nurses in terms of doing HIV testing, the manager came out and spoke so strongly and passionately about what it meant to be a manager of a bathhouse and have it play a role as a safe, health-promoting, sex-positive environment for gay men in the city, and not be this. And try to unpack that stereotype or that, you know, that place it sometimes occupies in cultural or social narrative of being that terrible place of disease and secrecy and shame. And it was, he was so proud to be part of that and to try and move to occupying that space. And we don't often, I don't think, work with businesses in that way as much as we should. We've done an analysis about access to condoms recently across the VCH region and found out some things where we probably need to actually partner a little bit, spend some time on those relationships with bars, gay bars that were asking to distribute condoms for us. We sent in a secret chopper in some of these places, and where we formerly thought that there was really great access, it was clear from the responses from the people working in these institutions that they didn't understand the opportunity to play this role in the community and what it meant in terms of engaging. And so it really said, okay, hey, here's where we've got some benefits from really partnering and listening to what the goals of that business owner was and partnering in and where we need to do some more work.
Great. Janet, did you? We have time for one last question. Anybody in the audience have a burning question? Kim, did you want to comment at all? No? She got put on the spot there, called out. Any last questions? Well, thank you. I'm going to close the panel. Or Janice?
Oh, I was just going to say that
last call.
That I think that the community evaluation really showed that there's a real appetite in the province with community-based organizations and ASOs to participate in STOP, and that we should really grab onto that opportunity and really use it as a launching point to engage these organizations, engage businesses, think about new ways of engaging different groups in the province to help move, the objectives and the goals of STOP forward. Because there's a lot of excitement and there's a lot of energy, and I think we need to keep fostering that and support that moving forward. And I think that was a really exciting thing that came out of the evaluation, was the amount of passion and excitement about supporting this new initiative. And so I just wanted to highlight that, and I think that's a real opportunity. And there's lots of learnings, and we can figure out how to do community engagement better and and make it more effective. But I think that, you know, there's that grain there, and that seed that we can grow into a very great integrated kind of program. So.
Thanks. So I'll just summarize some of the comments I heard today, that obviously community is critical to moving the response forward, and engaging and working with your partners is huge. We didn't always do the perfect job, and so we thank you for your patience with us and for being frank and sharing some of the tough lessons, but also for sharing the positive experience. And so we're all here. More details will be on the CATIE site. And I know Kath and Margaret spoke earlier, but their community engagement reports are also available on the BCH website and will be available on CATIE. And if you have any other questions, we're here. So I'll close the session. Thanks so much.